Hello, everyone. I'm coming to you today with a very special message, and I apologize to all of those individuals who follow the Caprini score and use the Caprini score for not having responded to this publication, and it's actually two publications before now. But to tell you the truth, I had missed those publications, and when I first discovered them was not too long ago. So, what the problem is, although well-intentioned, is trying to use administrative databases to predict the validity of a risk assessment score. And so you'll be seeing some things in this lecture that will be repetitive, and I apologize for that, except that I have to emphasize to everyone that the most important issue is to not use administrative databases inappropriately. They're very good for what they're designed for, which is including billing and so forth, and global health care, but not for individual risk assessment. Here are my disclosures. And this was a study involving 1,252,460 patients and an administrative database from 1,298 locations from January 2016 to December 2021. To the casual reader looking at this is, wow, this is an incredible array of data, and we're really going to learn a lot from that. Now, in this study, they used the Caprini scores and the Padua scores that were calculated for all patients without regard to medical or surgical specialties to predict 90-day VTE rates, followed by an additional analysis of 30 and 60-day rates in surgical and non-surgical patients. I don't understand why they would not include the improved D-dimer score, since it's been shown to be so valuable in the medical population. And also why they would just lump together all of the scores instead of using them for which they were designed. Now, altogether, 26.4% of surgical and 73% of non-surgical patients were included. This is primarily a medical study, and right away they're trying to show how the score designed for surgical patients doesn't work in medical patients. That's another story. Both RAMs were used for both medical and surgical patients, as I said, instead of using the tools the way they were designed. Nevertheless, good calibration and higher scores were associated with a higher VTE rate using both models. Outcomes at 90 days revealed a poor prediction of VTE for both tools. And I'll repeat this, but the poor prediction is related mainly to the missing and inappropriately coded data, not to the risk tools themselves. The advantages of the study include large sample size, rare event capture, longitudinal follow-up, and cost data. But remember, these administrative databases are primarily designed for billing purposes. The authors concluded that since both RAMs have a weak ability to predict 90-day VTE rates, improved RAMs must be identified before they can be applied to the general hospital population. And they had an invited commentary from other authorities suggesting a makeover of these VTE risk models. Now, the people involved in these studies were among the brightest and most respected academic folks in the country. That's the first thing. And the other thing is that the big point that we have been emphasizing for a number of years and has been beautifully emphasized by the Boston studies. The Boston studies, there are 18 studies, and they show that mandatory implementation of evidence care pathways are the key to lowering VTE rates. And that's the most important ingredient, and we'll come back to that later. Now, it was unknown who performed the risk assessments, whether all the questions were asked. We know they didn't ask about family history of thrombosis. Nine of the 39 Caprini factors were not evaluated, and the 2013 updates were also included on the basis that they weren't well enough validated. Were the legs examined properly to document varicose vein swelling or post-lipidic changes? Are you kidding? How are you ever going to determine that in an administrative database? The database does not indicate if the information collected regarding risk assessment were carried out by trained staff. In this famous Bateman study, where they said the Caprini score didn't work in orthopedics, they used only 12 of the 39 factors, and there was a 95% disagreement between the nurses and the doctors in evaluating it. So it's very, very important that you have it's very, very important that you have the proper people collecting these data. Um, Patients appreciate. The other thing is that we have a patient-friendly tools now because patients love to get involved in their healthcare, and that provides a good base for proceeding. You take that preliminary information that the patients gave you, and then with a trained observer can refine that for the final score. None of that is in an administrative database. The VA authors questioned risk factor definitions, but they never consulted the official guidance. The Caprini Risk Score.org, under the Caprini Risk Score for healthcare providers, we have hover words that go to either videos or data, abstracts or full articles if they're free, that indicate why we selected each risk factor for what the documentation was for each risk factor. And we've invited people from all over the world to critique this, and they have. And we've made changes in it to improve it better. And by the way, I would just like to acknowledge the world community. And I published a video on this previously about the 8 most brilliant people that helped put the Caprini score together. But there are others. And that's one of the reasons why it's such a good score, is because so many people have contributed to this, critiqued it, showed where it works and doesn't work. That's not in an administrative database. The authors suggested that the Caprini risk score was designed for general surgery, but mostly evaluated only in high-risk subgroups. That's not accurate. The Thresholds paper by Kirill Lobostov and Tomas Orbanik studied 4,207,895,000 patients across nearly every specialty and showed that there's a vast array and difference in risk scores between different groups and high risk and low risk and so forth. And of course, back to family history. Family history is one of the most powerful predictors of VTE and was not queried in the database. A serious omission handicapping the effectiveness of the Caprini risk score. There's also limited applicability here since 93% of the cohorts were male and no obstetric data was obtained in the database. And by this, I mean the specific obstetrical complications of placental insufficiency, growth retardation of the infant, multiple unplanned abortions, stillborns. And these can be associated with serious acquired thrombophilia defects. There is an absence of autopsy confirmation for suspected fatal pulmonary embolism. We know errors there occur all the time. There was insufficient information on the type, dosage, or duration of prophylactic treatment. The dynamic nature of risk assessment, essential for ongoing evaluation, including reassessment at discharge to identify candidates for continued prophylaxis, is not reported. Administrative databases, again, are designed for reimbursement and insight, not individual risk assessment. I'm sorry for being repetitive, but I feel very strongly about this, and I want to make sure that these points get taken. And I invite, of course, as we go forward, any critique of any of these things. Immortal time bias, where the study designs include a period in which the outcome cannot occur, potentially inflates survival rates or lowers VTE incidence. This bias is uncommon in administrative databases. Now, if you have a group of people, let's say, that are scheduled to get prophylaxis when they go home because they're at high risk, and they're followed for 90 days, Now, the tracking begins when they get their anticoagulant, which in some cases is 6 or 7 days after they are discharged. So that intermediate period of 6 or 7 days when they don't have anticoagulants, so they're not going to be tracked in the 90-day database. Some of them got DVT. So if some people got DVT, then they're excluded. So that represents immortal time bias, and it's very common in administrative databases. These issues with data quality, including missing information, indicate poor adherence to appropriate use criteria rather than a failure of the risk scores themselves, especially when the risk scores are applied into situations for which they were designed to be applied. And I've always held Alex Spiropoulos, and he and I go back to the very beginning, and we respect one another. Alex, with his improved D-dimer score, has shown wonderful things in the medical group, and I have shown some good things thanks to some other brilliant people in the surgery group. And we've maintained that because one shoe doesn't fit everyone. And applying each tool outside its intended domain, as I've just discussed, dilutes predictive performance and may partially explain the amount of area under the curves reported. Failure to repeat, failure to track family history of thrombosis, I would consider a fatal flaw. You all ought to go online and look at Emily's Promise. There's a nonprofit site because Emily Atkins, who was 23 years old, died after a fractured ankle was repaired because she got a fatal pulmonary embolus. She had a very strong family history of thrombosis, and nobody ever asked the questions. Since that time, there's some legislation to try to make sure that every surgical patient gets risk assessment and that these questions are asked. Coding systems often underreport or misclassify VTE events. Pulmonary emboli is frequently underrecognized on death certificates, as we said before, because of lack of autopsy data to verify the diagnosis. Missing present on admission flags confound hospital-acquired versus pre-existing events, and there's another opportunity there for immortal time bias. Coding transitions from 9 to 10 affect variable definitions and continuity. Administrative data lack timing information. When risk factors appeared to relative VTE events, back to immortal time bias. Dynamic scoring updating events occurring during hospitalization and exit scoring to indicate who would benefit from post-hospitalization anticoagulant prophylaxis. And I've already described to you that situation where that can be flawed if it's not tracked properly. Missing data bias underestimates the Caprini score's true predictive ability, nowhere greater than obstetrical problems and family history of thrombosis. Now, when I was discussing this with one of my esteemed colleagues, he said, well, I'd like to remind you there's another administrative database from Vietnam talking about how good the Caprini score is. Was it good for Vietnam, but not good for this? No, 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 no. Let's talk about the Vietnamese study. And I respect the Vietnamese. They've done a wonderful job tracking venous thrombosis. But I'd like to show you about what I've discovered when I delved into this administrative database. First of all, it's a multi-center observational cohort that looked at 2,790,027 adult surgical patients, elective and emergency. The adapted Caprini RAM, slight differences from ours, applied preoperatively to all patients. 30-day follow-up for clinically suspected and imaging confirmed VTE, and they reported 3,000 VTE events. It's a very low incidence for 2,795,000 patients. So that was a red flag. Exceptionally large reported sample, multi-center design, structured use of the Caprini risk asset, and further subdivision, which this is often a mistake that the Vietnamese did not make, that many people make, looking at 5 and above as the highest risk. No, 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 no. There's a whole continuum of risk assessment, as emphasized in the threshold study by Lobestoff and Urbanic, showing that as levels go up, especially from 7 to 11, there's a marked increase in the VTE incidence requiring prophylaxis. And another nice thing about this, it contributes data from an understudied Southeast Asian population. Now, if you take a look at all of these 2,700,000 patients on only four hospitals, that implies an extremely high operative volume, over 1.3 million operations per year, or hundreds per thousands per day per institution. So it's unclear where all of these cases represents through surgical operations. Now, I'm not throwing the Vietnamese under the bus. I'm just pointing out that when you go back and look at administrative databases, in order to come up with data about individual risk assessment, there are certain flaws that you run into. There's no detailed description of case identification algorithms or data validation, and this raises a legitimate concern about data auditing, potential duplication, case definition algorithms, or whether the data set actually reflects all admissions rather than true surgical operations. Very important. So the overall VTE incidence was below most base surgical cohorts. Go back to the threshold study again, with 4,200,000 patients. VTE detection based on clinical suspicion plus imaging, no routine screening. And there's likely an underdiagnosis of asymptomatic DVT and incidental PE. 30-day follow-up may miss substantially late postoperative VTE, which we know goes on for at least 90 days. And laboratory thrombophilia variables were excluded from the score. They're not usually done in those countries. And resulting RAM differs a little bit from the 2005 and 13 Caprini versions, but that's not a major problem. The adaptation is not fully described, limiting reproducibility. The ROC and AUC, or calibration analysis to quantify predictive performance, wasn't done. This is primarily univariate analysis. No, in addition, very large risk reduction for some factors, varicose veins, 50, and PVD 21. Effective size is inconsistent with the broader literature, likely coding or confounding issues. And that's not a problem of the Vietnamese. That's a problem of administrative databases. Let's keep that clear. Again, I'm incredibly indebted to the Vietnamese for their wonderful attempt to try to show the value of the Caprini score and reduce VTE in their country. Let's not miss that or miss my message to them. It's a wonderful message. They've been fabulous contributors. Attacking administrative databases. And here's some more data. The ball, 8,000 patients, 1.3% incidence of VTE. Panucci showed in the American College of Surgeons that scores of over 7 and 8 despite prophylaxis. And then again, we talked about the Lowestoft data, and we talked about the urbanic Lowestoft threshold data. And the Lowestoft data from 2016 was using pneumatic compression in addition to low molecular weight heparin to lower breakthrough thrombosis, and was very successful in this very high risk patients. And remember, the absolute risk estimates from this study should not drive guidelines. Risk models should be validated prospectively by trained staff, best administered by those responsible for collecting and verifying admitting history and physical. When I look at a study that talks about the Caprini score and I don't see a list of all the questions and how many positive and negatives there were, I look very, very askance at that data, suspect or suspicious of the data, because missing questions are really important. To ensure accurate and complete information, interrogation for all the risk factors must be done. And patient-completed risk Caprini score tools ask the patients to be involved in their care. These are the valuable things. These are how you get accurate data for risk assessment. And it's not easy, and everybody doesn't want to do it. And today, with administrative databases, electronic medical records, and artificial intelligence tools, the art of the history and physical is being lost. Risk assessment must be updated during hospitalization. I have a case I saw of a lady coming in who was a young woman with appendicitis, and she had a Caprini score of 4, but she had complications during hospitalization. And by the time she died of a fatal PE on day 10, her Caprini score was 12. And they went back and said, "Oh, we love the Caprini score, but look, it failed here. The score was 4 and she still died." Wasn't 4. Dynamic scoring wasn't done. It must really be done. The other thing is, and the big thing, is mandatory implementation of evidence care pathways using the Caprini score or other risk scores. Now, when the Boston University studies were done, it's 18 studies from 2014 to 2024. And they consistently showed that the VTE rate and the pulmonary embolism rate was well below 1%, and in some cases, a 0.5% or lower. How did they do that? They had a mandatory system of using the Caprini score, but if the doctors didn't initially use it, they just needed to state a reason. There was no yelling or screaming. And eventually, when the doctors saw how good the score was working, the skeptics bought into the program. So that was a nudge by evidence from your peers. And I can tell you, there's nothing more powerful than to present a doctor with their individual scores and individual results and show them how they could be improved. Most doctors worth their salt would jump at that. And that's the nudge that we need. There are also financial nudges that was very successful in the British system, patient audits or peer pressure, appropriate collection and implementation of risk assessment tools rather than any makeovers of the tools themselves are the key to improved results. Administrative databases may complement, but not replace prospective validation. Now, administrative databases, and I'm being repetitive here, but I want to make sure that everybody, when they look at a large million or 2 million study, doesn't say, "Wow, this is gospel." Administrative databases, billing claims registries provide large-scale data for VTE research. However, they were not designed for clinical validation of risk assessment models. They're useful for policy benchmarking for improvement, poor for individual thrombosis prophylaxis planning. Diagnosis codes for DVT PE may include rule-out studies, missing imaging or treatment codes, false positives and negatives. Administrative data cannot confirm if clinical questions were asked. No guarantee of accurate or complete variable documentation, and the problem of immortal time bias. The patients must survive long enough to be classified as treated, and this can create false appearance of benefit from prophylaxis. Remember what I told you about that study of people being sent home, but they didn't get their prophylaxis for a period of time, so they weren't begun to be tracked. And during that time, some DVTs occurred that were missed in the 90-day analysis. Immortal time bias. Now, to summarize, and I'm sorry I'm being so repetitive, but I think this is important. These two administrative databases attempt to evaluate the Caprini and Padua scores. The Caprini Risk Score requires complete clinical data. Databases cannot supply this. Major failure include risk factors are incomplete, only 30 to 40% available. Family history, obstetrical history that I've talked about, not just pregnancy or birth control pills, but again, placental insufficiency, growth retardation of the infant, repeated abortions, stillborns. These are important issues, and sometimes these people carry their thrombophilia defects for life. Those questions must be asked if you don't want to miss people and misclassify their risk assessment. The timing of the risk factors are absent, and dynamic assessment. Remember that girl with the appendix came in with a 4 and died with a 12. That reassessment must be done, and that's really hard to do in an administrative database. You can't compute the CRS correctly, and the weak prediction data. What does that reflect? Not the CRS failure, but the distortions are due to the quality of the data collected. Administrative database is not appropriate for individual risk model validation. I'm sorry to say this over and over. Prospective complete data collection is essential for its accuracy. Now, is the Caprini risk score really ready for a makeover? The answer is absolutely not. The Padua and Caprini risk scores work when they are used prospectively, including dynamic scoring, and used in populations where they have been properly tested. The key to reducing VTE, including fatal PE, is mandatory implementation of evidence-based pathways, employing nudges, economic nudges, peer review nudges, or other nudges, peer pressure, and these methods have all shown to be successful. And finally, performing a thorough and physical history and physical gives you knowledge about your present patient as if they were a good friend. So you'd never kill a friend and you'd never treat a stranger until you interrogated them, and then they become like a friend and you'd protect them. I'd like to thank you for your attention to this lecture. And again, I admit I welcome all and any constructive criticism.